Hi, everyone. Thank you so much for spending your lunch hour with us this somewhat gloomy Thursday. My name is Katie Collins. I use she, her pronouns, and I'm a senior program manager at Health Resources in Action and with the Community Health Training Institute. Thank you all again so much for being here for today's training, which is Upstream Approaches in Public Health, a 101 training. This is a free training offered through the Community Health Training Institute, which is funded by Massachusetts Department of Public Health and is brought to you in partnership between DPH and Health Resources in Action. We're very excited for the content prepared by some of our colleagues from HRIA today, Allison Shifley and Cynthia Feliciano. They're going to help us learn how those upstream approaches focus on addressing the root causes of issues rather than just treating the symptoms. They've got a packed agenda for the next hour. So I'll be turning it over to them momentarily. Just wanted to call out that we do have a live captioner here with us. So if you would like to turn on captions, just click the show captions button at the bottom right-hand corner of your screen. If you're not seeing that, you can click on the dot 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 more button to enable the caption button where you can see it and click show captions. Please message myself or Victoria if you're having any tech issues and we can try and help out. Finally, a note that your feedback on these trainings helps us continue to offer really great content. So we would really appreciate it if you take the feedback survey that Victoria will drop into the chat the last 2 to 3 minutes of the training before you head out into the rest of your day. So without further ado, I will now pass it over to Allison and Cynthia.
Hello, everyone. Welcome. Thank you for being here during your lunch time. I think at least in the East Coast time. My name is Cynthia Feliciano. I use the she, they pronouns. Excited to be in this space with you all. And I will quickly pass it to Allison to do a quick intro, and then we'll get us going.
Hello, everyone. My name is Allison Shifley. I use the she, her pronouns. I'm a director at Health Resources in Action and very excited to be here talking about upstream approaches with you all today.
Awesome. Thank you. So you can go to the next slides. So this is our packed agenda for today for lunch. And if we're not doing lunch and eating food while building community and doing upstream work, then I don't know what we're doing. We're very excited to do a welcome, sort of share a quick couple definitions of what upstream approaches are and some examples. We definitely want to make time for small group activity and for you all to connect. And of course, we always do try to do the large share group out. And close our time together. We can go to the next slide. And again, our goal is today to have you all understand the social determinants of health and then be able to describe at least one, if not, or a couple of upstream approaches in public health. We can go to the next slide. So first, we want to sort of share some group agreements. We would like for you all to do your best to be present and engaged. I know this is a hard time to do that, but we welcome it to do that. Take space if you can, and also make space for others. Take care of ourselves. That means, if you need to walk, to get food, water, stretch, do whatever you need to charge yourself. Please do so and be flexible both in the conversation and the content learning, but also with yourself when it comes to getting information. Grace and patience. We know that upstream work takes time, can be long term, and we'll share more about that. So I think having grace for the steps to take to get there and the patience to learn where we're at, it's important. And then make this a brave space. We want you to feel comfortable enough during this training to envision, to dream big and learn and make this a brave space for the great work that you're doing. So I'm going to pause here and welcome in the chat any other group agreements that you would like to add. And I see here from Jacqueline one mic. So yes, one person at a time speaking. Any other ones that folks would like to add to the space? If that is the one. Again, you can continue to add them in the chat. And we'll add that to our agreement and excited. If folks are agree with these, you can have a thumbs up physically or your emojis, middle, you're like not sure or down. I'm gonna see. I saw it. Thumbs ups. Awesome. Beautiful. Thank you all. And we can go to the next slide. Of course, we'd love for you all to introduce yourselves in the chat. I know we have a good amount of folks and might be expecting more, so please share your name, your pronouns, your role in organization, and I'm excited for this one. I'm looking for, what are you looking forward to this spring? I feel like I personally am excited to get out of hibernation in some way. Um, and I look forward to the spring as an example. I grow food. I love being outside, so being able to be in my garden. I'm looking forward to those steps there. But welcome those to share in the chat. Jacqueline, hi. So the Massachusetts Public Health Alliance, awesome. Springfield in the house, great. Hiking with dogs, that's awesome. Being light outside, yes. No more shoveling. I feel that 100%. I'm going to continue to welcome them. Body of water, flowers, more walks. Yes, sunshine. We all need to be outside. Sunshine and flowers, beautiful. Awesome. Welcome from Connecticut. That's great. First colorful things, playgrounds with little ones.
I
Being
cannot wait for
outside.
that. My kiddo needs to go to a playground real bad.
We all need adult play.
Yeah,
Yeah,
I need to
we
go
all
to the playground.
being outside, flowers, awesome. Beautiful. Great. I think we're all ready for the spring. Our bodies need it. And all that. Beautiful. Thank you. I'll continue to add them in the chat, which is going to move us along as we want to be mindful of our time. We can go to the next slide. Awesome. So I'm actually going to pass the mic to Allison to lead us through this part.
You go back once. There we go. All right. So we're here today to talk about upstream approaches and what those are, right? So let's start with our upstream approach, our kind of parable. You might have heard this before. But if someone is walking alongside a river and they see a baby in the river and they're like, oh my goodness, I gotta go save that baby. They rush in, they save that baby, they pull them out, baby's fine. They're like, oh, how did you get him there? And they look back in the river and they're like, oh, there's more in the river. There are more people and babies in the river. We have to get them out. Running in, saving them, saving them, saving them. And you're thinking to yourself as you're saving these babies, why are all these babies in the river? Like, what is happening, right? And so ideally, you would want to send somebody upstream, right, up the river to figure out what's going on, right? How can we prevent all these people from being in the river? And this is kind of our story about how we do our downstream, midstream, and upstream approaches. So downstream, saving babies, right? Midstream, you're a little bit like, what is happening, right? Like, how do we make sure people are okay? Upstream is, how can we prevent anyone from falling into this river? So let's dive in and talk about what all of these approaches are. First, we do need to talk about what health inequities are. Okay. So when we're talking about these different approaches, we're really figuring out how do we get upstream, right? How do we address any root causes or social determinants of health, which we'll explain and talk about in a little bit, which are those like underlying factors that create public health problems. And so when we think about health inequities, these are the difference in health outcomes that are systemic, avoidable, and unjust. All right. So our goal is for health equity. Okay. And so we have a definition of health equity, which is achieving the highest level of health for all people. All right. And so there is a larger definition from Healthy People 2030. And we'll talk about that a little bit more. But really, one of the ways to get health equity is to focus on the upstream approaches. So what are these different approaches? Let's define them a little bit more, right? So we have our downstream approaches. These are interventions, right? They seek to address the immediate needs. So this is rescuing those babies from the river. This is like the ambulance that helps, right? This is um, a hospital to go to, things like this. Yes, interventions, preventative measures. Okay, midstream approaches. Not everyone always talks about midstream approaches, but they're important because if our goal is to keep moving upstream, it's not like a binary, right? It's not like you're either at the basin of the river or you're at the top. Like there's none of that. So midstream are really those interventions that seek to reduce exposure to the health risks, right? So this is helping to get babies out of that river before things get worse, right? Right? We want to prevent anything from happening to them. So either in midstream approaches, depending on what you're doing, either you're like improving physical conditions or you're trying to promote different healthy environments. It can look differently. And then our upstream approaches are really seeking to reform fundamental social and economic structures, right? We are power shifting here. We are including all folks in decision making and opportunities. We're going upstream, right? We want to keep those babies from ending up in the river. So let's show some examples of these. So for our downstream approaches, we talked about this a little bit, but again, these are the effects and the impacts of health inequities, okay? So some examples of downstream approaches are mental health counseling, okay? This is needed, necessary, awesome, and still a downstream approach because it's addressing immediate health needs. Substance use cessation programs, also needed, also amazing, downstream approach, right? This one sometimes get people's, but chronic disease prevention programs are still a downstream approach because we're not changing the underlying root causes that are causing some of those chronic diseases. Anybody have any questions or comments on downstream approaches? And you can say them out loud, you can put them in the chat, anything that you want to do.
Can you say more
Do
about
that
chronic
throughout.
disease
Oh,
prevention?
Margaret, sorry, can you repeat that?
Can you say more about chronic disease prevention? Because I'm thinking like chronic asthma, like reducing pollution. Wouldn't that be upstream?
So it depends what's happening. So for asthma, right? Um, or for other things too, chronic disease prevention programs aren't always addressing the root causes. So for asthma, some of this is the buildings that we live in, right? So are we changing policies, building codes, etc., in order to prevent asthma in the first place? Like, are we at that level, or are we just trying to um, do an intervention that like addresses that current need?
So like providing everybody with air filtration systems would
Right.
be
That is a downstream
secondary.
approach because it's not changing
Right.
the root causes of the issue. It's just kind of mitigating what's happening right now.
Thank you.
Yeah, absolutely. Other questions or comments? So a lot of programs do live here in the downstream approaches, right? Of programs that we design and we have. And again, we're not saying these are bad. It's just saying that we do want to move upstream so that we can have health equity for everyone. And it's a mixture of things. And we'll talk more about that. So let's move to midstream. So again, these are the ones that seek to reduce exposure to health risks. So with the asthma, maybe the air filters could be here, it could be downstream. Sometimes they are in the middle. It's not always a clear definition. But these interventions are more about changing the cause of the health inequities. So these ones, for example, are improving standards for health housing conditions. So we're talking about those things that are still happening now, right? We are still trying to reduce exposures, but we're not necessarily addressing the underlying root cause about why these things are happening in the first place. Yes, they are very reminiscent of levels of prevention, primary, secondary, tertiary. And in fact, sometimes they just map right on there, right? So thinking about that. Questions, comments here, right? We have some examples. Cultural competency trainings or other similar trainings are more midstream approaches. Having people, like if your program or anything is about connecting folks with social assistance programs, whether that's helping with rent or food or anything like that, it's more of a midstream approach. All right, so let's talk about upstream. So upstream, these are changing and dismantling the causes of health inequities, and they focus on the structural social determinants of health. I wrote the wrong thing on the slide. So this is examples of like advocating for rent control, right? Decriminalizing substance use, restoring lands to indigenous communities. And these can seem really big and really broad. And you're like, how does my program or my organization fit into this? And it's about this collective movement to upstream, right? We can't do this on our own. It can't just be me. It can't just be me and like another organization. It is a collective thing, right? But it's about the reforming those fundamental social and economic structures. Yeah. Hafsa too?
Hi, I just wondering if um, advocating for rent control is actually upstream. I feel like it's midstream because uh, houses, having the houses is to me what should be upstream, and then the rent control, if there aren't enough houses to begin with, then it's not, we still like haven't addressed the problem.
Yeah, absolutely. So this is an example where there could be multiple kind of upstream approaches. So rent control is upstream because we are advocating for like new policies, new systems in place. At the same time, you're right, we still need to make sure there are enough housing options for everyone. So a lot of these upstreams approaches aren't going to exist in a vacuum, right? We know that if we advocate for rent control, that's not going to fix absolutely everything, but it sure makes a big difference to a lot of people who are paying rent, and making sure those increases don't happen all the time or in humongous amounts. Is that clear?
Yes, absolutely. Thank you.
Yeah,
Super helpful.
absolutely. Yes. So it's a both and, right? It is upstream and there's still more to do upstream for housing and so many other things. Other questions or comments on these three approaches? So one thing I will mention is, like I said, it's a little bit of a gray area. We just want to keep moving as upstream as we can, right? And so it's a little bit of identifying where work is right now and how you want to move up, and we're going to do that a little bit. But sometimes things fall into multiple categories here. And it depends on the approach, like, it depends on what we're doing on how that approach or which approach it'll be. Okay. So again, I mentioned that to get to upstream approaches, we are focusing on social determinants of health. So I'm going to hand it over to Cynthia here, who will explain a little bit more about what that is.
Thank you, Allison. Yeah, so I am making the assumption and would love for folks to raise their hand if they have heard the term social determinants of health. Or the acronym. Show of hands, maybe. And if not, well, there you go, a couple of hands. Awesome. So I will sort of share a little bit of the description. So again, they're really conditions in the environment with people, all of us. We are born, we live, we learn, we work and play. Worship as well and age. And they affect a wide range of health, functioning, and quality of life outcomes and risk. And they're grouped into 5 domains. So I'll go more into all of these if you can go to the next slide. So economic stability is one, right? Employment, food insecurity, housing instability, and poverty can determine our, our health in general. The other domain is, you can go to next, education, right? The early childhood education and development, enrollment in higher education, high school graduation, and language and literacy. You can go to the next slide. Social and community context. This is really important. Civic participation, you have discrimination and just all of that, incarceration and social cohesion. We can go up to the next one. Health and healthcare. So access to healthcare, primary care, and then health literacy. And finally, the other domain is neighborhood and built environment. So access to food that support healthy eating patterns, crime and violence, environmental conditions, and quality of housing. Sorry. Excuse me, you can go to the next slide. So all of these are important to having context when we are trying to do any upstream approach. And we'll always recommend as well for any midstream and downstream approach and work that we want to do. And this is a great visual example of upstream and downstream approaches. So in a lot of the work in public health that I have seen and continue to do is really we look at the right side of the screen here, from risk behaviors to citizen injury and mortality. We want to lessen these, right? We want to do that, and this is where sort of the downstream programming approaches are key in doing. And once we start moving to the left side, looking at living condition, institutional power, and social inequities, this is where we want to move towards to address, to name, and lift up there. So you see here, there's some different information under these that we're trying to do. And on the next slide, I always give this example that I use for myself, but also in the work that I've done. My background is environmental science and education, mostly on like food systems and work. Also working a lot with like BIPOC community. And social determinants of health are very indifferent. So I'm starting with, life expectancy of like Latina women, in the United States context as one of them, is rare and changes. That can lead to a lot of chronic diseases that happen. And a lot of that in downstream approaches is like, oh, we need more physical activity. It's just a risk in a behavior that I have, as an example. However, there's also a lot of more context of why I may not be engaging in physical activity, right? As an example, to get to certain foods. In this context right now, there's a lot more that I won't share, but politically is also unsafe, so that adds up to it. So my physical environment might not be welcoming. I'm gonna have sidewalks that are comfortable to walk in, etc. So all of these adds to my chronic disease as an example. And also, let's say, there's laws and regulations that make it hard for you to look a certain way or be a certain way to be on the streets, as an example. Or sidewalks are not being cleared or prepared, so it's unsafe, and that's part of laws and regulations. Let's say a local DPW or a city municipality may have limitations of clearing or fixing a sidewalk to make it more accessible. And all that adds to the social inequities that unfortunately we're in today and have continued of, immigration status as an example, race, ethnicity that comes up, and gender, etc. So I'll give you that example in context, and I imagine you all can probably come up with some of them of how, whether an individual or group that you work with, or community that you work with, you're trying to do downstream approaches to help, prevent X chronic disease, whatever that might be. Access to that information is important, but I think, and we want to also be able to have the context of the social inequities, institutional power, and living conditions that we all have. One name this can be overwhelming, right? To know all that information, to try to be like, what I'm doing now is helping, which is always helping, and it's supporting this work. And we know as a collective, we need to work towards addressing upstream approaches. So I'll pause here if there's any questions, and also welcome Allison if you have any other thoughts to add. No? And if none, can go to the next slide. We do have a poll, so we want to hear from you all to think of examples if which of the following are downstream, midstream, or upstream approaches, or what you think fits best. So, again, this is a fun exercise to get you going, so we can do the poll when you're ready.
So you're answering these 5 questions. Choose if it's a downstream, midstream, or upstream, or whichever one you think fits best. Couple moments or a few minutes here to go through and think about them. Know you're applying what we've just talked about. Almost there. We have about 2/3 of answers in. Ten more seconds and then we'll close the polls. We'll see where we are. All right. Can people see the results on your screen? All right, so let's go over these because we've got some answers all over here. So we asked, what approach is this for affordable, high quality childcare? Does anyone want to come off mute and share their thoughts about this one? And I'll say we worded these vaguely, right? We didn't put too much information in there. And you can make a case for a couple different ones here. We said midstream. Substitute. Let's see what you said.
I actually said upstream because
Yeah.
I thought you need policies in place to require both affordable but also high quality. So I was thinking about policies that's
Yes.
meet.
So if we had put policy in there, absolutely would be upstream. And you're right, we probably need a policy to make this actually happen, right? But if it's just that we happen to find an affordable, high quality childcare, it's midstream. Because worded that way, it's an intervention to try to mitigate existing inequities, but doesn't get to the root causes of it, right? So if we had talked about policy or other things, it would move upstream. Other thoughts or comments about this one? Right. Let's talk about the next one, which is reproductive health services. Yes, Kimmy.
Yes,
Yes,
yes.
we worded these very vaguely, so if you wanted to say it depends to all of them, you can make an argument for them.
Yes.
So reproductive health services, we have this down in downstream, but I'd love to hear people's thoughts because we had a lot of folks put midstream, some downstream, and some upstream. So let's hear your thoughts. Anyone want to come off or put it in the chat?
I could have made an argument for all three of them
Yep.
because it was so vague. So I went with midstream because I felt like it was middle of the line. But for me, it depended on what the individual is that needs the reproductive health services. Are
Yep.
they coming in because they're already pregnant and didn't want to be pregnant? Or are you, you know, giving them accessible care, before, like preventative care from getting pregnant, like all the things. I just went middle ground.
Yeah, absolutely. And so, just like Kimmy mentioned in the chat, a lot of this is it depends. It depends what it is, right? If this is a reproductive healthcare clinic, it's probably downstream, right? Because we're in that primary care, right? Um, if it's something where like everyone gets access to reproductive health services, and maybe that's a policy, or maybe that's just like the system we have, right? It would be more upstream. Monica, you picked downstream because you placed it on the clinical side. Yeah, absolutely, right? That primary care, if we want to map it that way. Absolutely. So what approach is this next one? Providing health materials in multiple language. We had some variety on this one as well. For this one, we put midstream. And we put midstream because it tries to mitigate those existing inequities or promote health behaviors, but again, it doesn't get to root of health inequities. And we wanted to include this example in here because so many of us do this, right? We either have our health materials and then we're like, oh yes, we should translate them to be in other languages, whether it's like actual healthcare instructions or it's other public health organizations or applications, everything. But it doesn't get to the root of the inequities amongst different populations. Other comments or thoughts on this question?
I actually put downstream
Yeah.
because I really hyper focused on like the definition of it of like address immediate health and social
Mhm.
need. And I think a lot of times what you mentioned is what we do, like it's an afterthought, like, oh, we have to translate this thing. And it's like
Yeah.
it should more so be an immediate thought, especially if you're in tune with your population that, oh, we need this from the outset. Like it needs to be in multiple languages and not just starting with the English and then eventually adding on because you're missing out. There's still a gap there.
I think that's a great argument for it to go in the downstream, right? If we are just making things in English and then afterthought thinking about other languages, that is more downstream, right? We're just like, that is trying to adjust something more in the moment. And we're like, oh, and that would also apply if we're just putting them through like Google Translate versus having someone who actually knows, speaks, writes the language, translate them to make sure that they are in the correct dialect for the audience that you are trying to reach, right? So thinking about it different ways, yes, we do not want to just use Google Translate. Um, awesome. So the majority of you all put midstream and downstream, and there are arguments to be made that it could be either. And this just goes back to, yes, we listed these three approaches. They're blurry between them, right? It's blurry. It's all about just moving up where we can, right? Okay, our next question, expanding healthcare coverage to everyone, regardless of citizenship status. The majority of you put upstream, and that is what we had as well, right? It is upstream approach because the attention is on the factors that create inequities, right? So that's why we put there. But any other thoughts or comments for this one? Yeah, Samia.
Hi, I'm Samaya,
Fine.
and I agree. It addresses more of the root, like the social drivers and determinants of health. So, like poverty, the lack of access to coverage in the first place, being historically marginalized, and that led me to think about, well, what are state legislators doing to expand that coverage and increase access for example, immigrant populations, and moving upstream, thinking about how that collective action can move towards the federal level. So, yeah, thank you for posing that question. I thought that was a great example.
Oh, awesome. Yeah, thank you for talking all about that. And um, people could say we can move this even more upstream, right? We just like we're expanding healthcare coverage. We just have universal healthcare. Like, there's ways to keep expanding this. Absolutely. All right. And our last question talked about the food pantry. And like you all have been saying, this could be multiple things, right? We needed more information. Everyone needed more information here. Most of you put downstream. Why did people put downstream? We want to hear that because we put downstream. We also put maybe midstream. Let's see. Anybody want to share? Yeah, absolutely. Oh, Kimmy, go ahead and then Hafsa too.
No, just this one because it feels like a direct intervention for like a crisis situation.
Mhm.
So like yes, there is like for example, I know like BMC has like their preventative food pantry. Like there are like systems that you can maybe put in the midstream category like you did as well. But typically when people are like thinking, if we're really simplifying the question, then that's kind of what we're going through is a direct, here's someone who needs food and here's the food for them.
Yeah, absolutely. Yes. And Sarah put in the chat, people are currently in a food insecurity situation and need immediate access. Absolutely. Hafsatu, you put your hand up. Would you like to add?
Yeah, along those lines of, people being in a crisis, just not thinking about employment, for example, or even further up, good education that would lead to good employment so people have good income, decent income to afford the food.
Yep.
So I think I said it's way down there. being hungry is related to all of, it's like a chain. If you go
And
up the chain,
absolutely.
you can address it. So I agree with everybody else.
Yeah.
Yeah.
Absolutely. And like you were just saying, like you were just listing off a few different of the social determinants of health, right? If we have access to good health care, if we have access to education, then ideally we have enough money and access to healthy food and we don't need food pantries, right? And so this is always the interesting thing too, is that as we move upstream, the idea is that some of our nonprofits or topic-oriented things, essentially we put them out of business, right? Like ideally, food pantries wouldn't have to exist. But they do. Anna, you had your hand up. Did you still want to say something?
Yeah, I actually put it in the chat, but
Oh,
what we often say in food banking is that we can't food pantry our way out of food insecurity. So
yes.
food is the first thing that gets our neighbors into our door, but it's everything else that we assist them with that actually gets them out of food insecurity and self-sustaining.
Absolutely. And so that is a really cool, like if you're getting them in the door for to get food, amazing downstream approach, but
Hmm.
maybe you're making it more midstream by then connecting them with other
Absolutely.
resources, right? And that was one of our midstream examples before.
Yeah.
Yeah, and then to add to this one, again, all of these approaches can dap into all three of these like midstream, downstream, and upstream. And I would name two to keep in mind related to food. A lot of food pantries and food banks, at least in the state, really also organized to do upstream work related to policy. They are key, institutions that are working closely with food insecure individuals and families and communities. So an example for the SNAP cuts in November, food pantries, food banks, and all of that continue to do both. You can do both, right? They continue to serve food, do the downstream approach, and also engage in the upstream approach of policy and advocacy and making changes there. So there's a role for all of us there. The capacity is the question, right? I think that's where we're at. But wanted to uplift that too, that all of these can include, you can have different approaches, different programming, different projects, different collaborations, partnerships, etc., to address all of these.
Absolutely. And so just another way of looking at this is what we call our equitree. So it's looking at health equity that we have in a lovely tree shape. Here it is. And so when we're seeing those health outcomes, which we call the leaves of the tree, because that's what you can see, right? But as you kind of work down the tree, you see, oh, there are the social determinants of health. That's what we call the trunk of the tree, right? That built environment, that education, etc. And as you continue to go down to the roots in the soil, those are the root causes, right? We need to change down there, and that's what we say upstream, but this one is a trunk or a tree metaphor, right? But those are the upstream things that we need to change. So just wanted to put it in another visual form for people. See what option lands with you the best. Right now, we want to give you a chance to talk with each other. So we're going to put you in small groups for only about 8 minutes or so. And we're going to have you answer, where are you currently in your work, right? Can you identify which approach your work is doing right now? And it could be a mixture, right? And what is one action step that you can take this year to try to start moving your work upstream? Or if it is upstream, how do you maintain it at upstream? Because that can be really challenging as well. So we're going to put you in small groups, again, only like 8 minutes, and then we'll come back, have a few people share out, and we'll wrap up for our hour. Okay? So Victoria, go ahead and open those rooms. And if y'all have any issues with that, let us know.
Hello, everyone. Welcome back to the main room. Apologies in advance if we cut you mid-sentence. I know it happens all the time. We hope that the time in the small groups were rich and a great way to connect. I know it is still limited time, but we hope we were able to at least get to see lovely faces and see each other. And right now, we'll give a couple minutes for these two lovely souls that would like to volunteer and share maybe one approach of the work that you're doing, one example of the work that you're doing. That might be downstream, midstream, or upstream, and then one action step you're hoping to take this calendar year. So wondering if any brave and lovely soul would like to speak to the space. Samaya, am I saying it right?
Yeah, you did.
Awesome, thank you.
Yeah, I don't mind sharing.
Thank you.
Um, so I, for context, represent Community Forest Bias, and we're a collective based in the Cambridge, Boston area, composed of Black and Brown youth, and the ultimate goal is to organize to uplift our communities from systems that harm us, dedicated to building community-led structures and initiatives and processes away from systems such as gentrification, capitalism, etc. And we started out in 2020, and one of our main demands was to advocate for a community safety response program within the city where in moments of crises that community members are experiencing, um, in moments of crises that the right professionals would step in, like mental health workers, social workers, and not so much punitive action from law enforcement, because we've seen time and time again that in our community there's been more harm done than good when the inappropriate professionals are stepping into those situations of crises where whether it's has to do with substance abuse or mental health. So I would say it's been a mix of downstream, midstream, and upstream, but it started off as us meeting as organizers and as community members to address what's going on, and then slowly that started into began to look like advocacy. So going to City Hall, demonstrating, and using our voices to emphasize, hey, that this is an issue that is really important. We need to address it. And eventually that turned into us coordinating these meetings with city councilors to discuss the issue at hand. And eventually we were able to draft up a policy order to present to the city council to ensure that this is something that is legitimate and that we want to translate into meaningful action. So policy order 149, for example, was advocating for something called HEART, which is the Holistic Emergency Alternative Response Team. And so just to sum it up, it took about 2.5 years of advocating at the local level with our community members and with the city councilors to advocate for this policy order to be passed. And lo and behold, by 2023, late 2023, it finally passed, and HEART is now in existence. It's its own organization, and it's grassroots where folks with lived experience are leading the program to provide the right care to people undergoing crises. And so I think we slowly worked our way upstream. And to the second question, how can we maintain that? Continuing to engage at the community level with other organizations who are doing similar work, having those connections with the stakeholders like city councilors, and continuing to coalition build and put our voices out there essentially. Thank you again for posing that activity. It was a great exercise.
Welcome, and thank you so much for sharing just like your journey of all the approaches, right? All of the steps that you took to get to upstream, but also continue the midstream and downstream. And and the actions that you're taking. I think I saw some reactions from folks, and welcome you to also share in the chat any links for the great work if you want folks to uplift it. I know we're close at time, and I think if folks, yeah, anything you want to add, Allison?
No, I think that was a great example. If other people want to put them in any examples or thoughts in the chat, that would be great. We do want to make sure that we give you the link to our feedback form because we do look at all of these, and Victoria just popped it in the chat. You will get a copy of these slides. Also, we have some different resources through the Community Health Training Institute. There's a spotlight form if you want to submit a resource, an event, a group, etc., to be highlighted on our LinkedIn. Please feel free to do that. This video, because it was recorded, will be posted in our training library, and we also have lots of other videos in there. Feel free to take advantage of that. Watch any of those, share them with your colleagues, and please follow us on LinkedIn for more information and updates on trainings. Otherwise, thank you so much for joining us today. We really appreciate it. And Cynthia and I will hang around here for a little bit if anyone has additional questions that we can answer for you.
Yeah, thank you. It's been a pleasure to be in space with you all. So, and I think if you go to next slide, Victoria, our contact information is there as well. So if you have other questions, pretty reachable. Excited for the great work that you are doing. So I am immense gratitude for all the great work and taking time on your afternoon to do this.